Cancer during COVID-19, what you need to know and how it's impacting treatment. Welcome to Tumor Talk. I'm Wes Wilson, and thank you for letting us join you on your cancer journey. Today, we're talking all things COVID-19, how it affects cancer and treatment. You might already be aware that cancer patients, families, and caregivers are disproportionately affected by this pandemic. Cancer patients are twice as likely to become infected and are significantly more likely to have adverse effects. Joining us today to shed some light on this topic is Dr. Mudit Chowdhary, Chief Resident Physician in Radiation Oncology at Rush University Medical Center in Chicago, Illinois. Thank you for joining us, Dr. Chowdhary.
Thanks for having me. I'm excited to be here.
First, let's talk a little bit about why are cancer patients at such a higher risk?
It's a great question. So I think there's several reasons for this. First of all, cancer is a disease that affects the immune system. We call it immunosuppressive, which means that it causes people to be more susceptible to some infections, including viruses like COVID-19. Cancer treatment for these patients in and itself can also decrease the immune system's capacity to fight off infection. So that further increases these patients' risks. For example, one of the side effects of many cancer treatments is a decrease in some of the patient's blood counts called lymphocytes, which help fight off infections. And in fact, a series from New York Presbyterian in New York City showed that 90% of COVID patients at presentation had lymphopenia or these low lymphocytes in their body. So again, that's something that we cause, and that's something that these patients are already showing up with. Second, we think that COVID patients with cancer are typically older, and they have a lot of underlying comorbidities than COVID patients without cancer. And that's been shown now, like increasing age and more comorbidities have been associated with higher mortality with this infection.
Right.
And then lastly, cancer patients are frequently visiting the hospitals for treatment as well as monitoring, which places them at higher chances of just being exposed in general to the virus.
Right. So just going in for checkups to get test results, going in to get follow-up scans, CTs, chest x-rays. Every time you go into the hospital, you risk being exposed.
Yes, absolutely.
So what are we seeing in your clinic right now? How are things looking?
In our clinic, we're still continuing treatment because cancer is still a very frightening and scary disease, and it needs to be treated. So we're continuing onwards with that. We're taking precautions to try to minimize the risks for our patients. Some of these include having universal masking for all patients, as well as staff members that work in the entire hospital, including our clinic. We have temperature checks at every entrance to monitor for fevers. Before patients come in for their daily appointment or treatment, we call the patient beforehand and have some screening questions to see if they may have been exposed or have any other risk factors. We're now increasing our hours as a cancer center, both on weekdays as well as making sure we're open on weekends. And this allows us to spread the appointments between patients around and make sure there's less exposure between seeing other patients. And then finally, we've had a big shift towards telemedicine, including both consults and follow-ups. We're doing probably 90% telemedicine at this point.
Right, because I guess there's no need for patients just to come in for a test result. If you're finding out if your cancer is like Herceptin positive or triple negative, these test results are stuff that usually you don't really need to physically be there. I think there's a good argument for the empathy over not as optimistic test results to be face-to-face, but in terms of risk exposure, it's probably something that can be mitigated, right?
Absolutely. You hit it right on the head.
So for especially, let's start with the radiation treatment. Let's say I had a tumor and I needed radiotherapy. And for those who may not know, radiation is a very common treatment. 66% of all solid tumors, whether they're new diagnosis or they're reoccurrent, receive some sort of radiotherapy. And I was concerned about, going in to get radiotherapy, going to the clinic to be exposed, or even let's say I'm worried that maybe radiation will weaken my immune system. Should I change anything? What should I do?
That's a great question. I think the first thing I would do is talk to your oncologist, especially your radiation oncologist. We're happy to talk to you and try to discuss the game plan for your disease to make it as safe as possible. Radiation can definitely decrease some of the blood counts in the cells. Usually it doesn't do it to as great of a capacity as, for example, a chemotherapy, but it
Mhm.
can. So it's very important to talk to your doctor. But like you said, it's still a vital part of cancer treatments, even at this time. So for most cancers, we're still continuing. For some lower risk cancers, we are delaying radiation therapy to a future date. And then in other cases where treatment is needed, but we can shorten the number of actual daily sessions that you would need to come for, we have adopted that. For example, in breast cancer, the standard treatment course at this time for early stage is around 15 to 16 treatments of daily sessions of radiation therapy. We've shortened that to only 5 sessions
Mhm.
to get a good balance between safety from getting the virus itself, as well as controlling your cancer and trying to make sure it never comes back.
Right. And so I think for a lot of these, for most treatments, it's going to be all about talking to your medical oncology team. Keeping them apprised of your symptoms if you're getting sick, and what the decisions are going to be. I think we're not going to have a universal answer for everybody out there, but it's going to be based on your type of cancer and the staging of your cancer. So let's move into one of the easier ones, I guess. Next would be surgery. Obviously, surgery can keep you immunocompromised for a bit. And definitely a visit to the hospital. Hard to do that one from home, telemedicine. What are you seeing changes being done surgery-wise? I know here in Toronto, a lot of the surgical suites have even been converted to ICU rooms for COVID-19.
Yeah, we're seeing similar findings. So a lot of the ORs in the city of Chicago have also been converted to ICUs. The few ORs that are still currently active, we try to get the most high priority cases in there, stuff that cannot be delayed. So, for example, like a sarcoma surgery is essential to get for patients, and that's something that can't be delayed at this time point. But as a whole, I think our surgical colleagues have probably had to do the biggest changes with COVID-19, like for exactly like you said. This could include administering some sort of neoadjuvant therapy before the planned surgery in the future, such as in breast cancer, for example, giving some anti-estrogen pills, or in certain cases, giving radiation therapy before the surgery, again, to take care of the cancer right now and to avoid the cancer growing, but still allow for a surgery at a later date.
Yeah.
Another case.
And I'll just point out for people, because we'll be talking about chemo in a second, just that the hormone therapies, like the anti-estrogens, and they're used for breast cancer, these do not weaken the immune system. They don't make you immunocompromised like other chemotherapies will. So these are safe to take for a COVID-19 perspective.
For certain surgical cases, we have also been looking at are there alternative treatments available to make sure you still get your definitive cancer care. A good example that I can give you is for early stage non-small cell lung cancer, where currently the gold standard treatment is surgery, but a good alternative that's been increasing in use over the past several years is a type of high dose radiation therapy called stereotactic body radiotherapy, or SBRT.
Yeah.
It's where we deliver a few very high doses of highly targeted, highly focused radiotherapy to a specific spot at the tumor. And it's shown very good outcomes so far. Currently, still trying to do trials to show how SBRT compares to surgery head to head, but the early results of it are very encouraging. So during this time when ORs are kind of tied up and we can't get patients to surgery always, this is a very good type of alternative strategy that exists there that we're able to offer patients, and so that way we can give them definitive care at this time without the risk of having to go into the operating room or being stuck in a logjam waiting to find an open operating room.
Yeah, I think it's a good strategy when you can't get surgery. And we have a series of radiotherapy coming up, both on how radiotherapy actually works. So we have videos for that if you guys are interested, and we have another video coming up to be released talking about kind of just dispelling some of the myths of radiotherapy that is very safe. But one of the things I'll just say for this is radiotherapy is a very interesting treatment strategy, a motif, if you will, because it works on so many levels, and I think people don't really get that. It can kill cancer cells directly, inducing DNA damage, but it also has an immune response. It can make tumors more immunogenic and allow the immune system to attack cancer better. There's been studies, and it also can do remodeling of the vasculature, and this can be really important because tumors can be quite hypoxic areas. Blood flow is hard to get in there, and while this has a lot of effects, I won't bore people on tumor metabolism. The key thing to understand with that is with better vasculature flow through the tumor, chemotherapy drugs can get into the tumor better and actually be more effective. And so I think a lot of people don't think of all the way how good radiotherapy can be for cancer treatment. And that's why we're going to be doing a small series, a couple videos on radiotherapy. And maybe we'll get you back again for one of those.
Yeah, absolutely. I'd love to help dispel some rumors. Absolutely. I think it's funny. A lot of our patients come in and they're absolutely beyond terrified before starting treatment. Then at the end of their treatment course, they tell me, like, "Doc, that was actually much, much easier than I ever thought would happen. And it's actually one of the easier parts of my cancer treatments." And so it's always gratifying to hear. But absolutely, I can completely understand where someone tells you, "Oh, you're going to get radiation therapy," how it might scare a person.
Yeah, I mean, I think that pop culture and media plays a big role in that. And I think, radiation is always a dangerous thing. If it's not giving you superpowers, it's killing you in the movies. So I think that's how most people have experience with radiation, right? Most people don't work with radiation.
Yeah, absolutely. I think everyone just thinks of, Chernobyl or some sort of accident when they're thinking radiation therapy, and it's not to their fault. There's no fault of their own, but that's what we're here for. We're here to educate and to show why a patient may need it and how it may benefit them. That's our job, and we love doing that to help with.
I know from some studies, especially in breast, that delaying surgery for sometimes doesn't really have an effect on outcomes. So I think there's some cancers and some stagings where they are. So I know in Texas, they are being able to delay a lot of these surgeries, even up to 90 days in some cases safely. And in California, for breast, again, I've been reading a lot of breast studies recently. I know that they have definitely been prioritizing. So, triple negatives, metastatic diseases, they're making sure that people who need it, who would prioritize the patients who can't wait, are getting it. So I don't think, from my understanding, you can tell me what you've seen in the ecosystem, but I don't think there's any alarm bells to say that you can't get the treatment you need for cancer because of COVID at this point.
Yeah, absolutely. I think you phrased it very nicely. I think for many different cancers, there are, different priority groups. And for the high priority groups, we're still getting them in for their definitive surgery, because especially if there's a chance for cure right now or something that's very aggressive that needs to be taken care of, it can't be delayed, because we don't want to have a negative outcome from the cancer. You have to do a good job balancing the risk benefit ratio and that. But in those cases, the show must go on. You have to do the treatment.
So we're going to come now into one of the trickier ones, and that is going to be chemotherapy. This is where the most immunocompromised treatments really are involved. This is also one where in certain areas, you have to travel to go get your treatment. It is the one that has the most active clinical trials. And clinical trials, as someone in the clinical trial world, usually they're at specific centers, and they're not always the closest center to you. And again, we've been advised not to fly, not to travel to these areas. This is a tricky one. So how are you seeing any changes from your colleagues for chemotherapy treatment?
Yes, that is very tricky. So, as you know, a vast many number of cancer patients require systemic therapy, including chemotherapy, as part of their standard of care. There are certain things that are being done to try to minimize some of the side effects from it, as well as uh, avoiding um, patients from getting sick from coming into the hospital too much. So some of this can include using pill forms of chemotherapy rather than IV, so they can stay at home while doing that. So I've seen some patients in our center, they've had the time between chemotherapy cycles lengthened by kind of giving a different dosing regimen of the chemotherapy drug, as
Right,
well as
right.
sometimes decreasing the total number of cycles. So, for example, in certain cancers, after a year or 2 years of maintenance therapy, it's kind of on the borderline of should you continue or should you not. And in that case, kind of making more of a decision to be safe and pause for now and give kind of like a chemo holiday and follow up with scans rather than continuing to bring the patient in when the benefit of it may be a little less certain.
Right, right. And I think something people should look into is if you are on a trial, contact the trial team. Maybe it's going to be talking about delayed and just go into standard treatment. And or even if you are in a position where you're not in treatment, but there's no cancer centers near you, maybe look at if they offer temporary closer housing. I know many of the hospitals I've worked for do have these centers set up. Sometimes they're owned and operated by the hospital. Sometimes they're operated by independent philanthropic groups. And they will sometimes have ability to put people up either in their own housing or in hotels, so that you don't have to do that travel back and forth for treatment during this pandemic. So try to look into that. And again, it's going to come back to a lot. Talk to your medical oncology team if you have concerns, and they can talk about changing up treatment dosing times and stuff. We've talked kind of about, if you're actively seeking treatment and you have active disease, you're at higher risk because you're immunocompromised, and that means you really got to work, really got to stay in if you can. But also family members and caregivers, if you're around people who are being treated with active cancer, you got to be really vigilant too. So you have to don't go out unless you absolutely have to. When can someone who's finished treatment, let's say they finished not just their main treatment, but they've done their follow-up preventative chemo, how long until you'd say they're not at risk anymore?
Yeah, that's a great question. I think we don't have a good answer for that right now. I think cancer, I think of it more as like a lifelong disease in that sense, where we want to continue monitoring you even when it's been, 3-5 years out, that we can kind of decrease the frequency of seeing the patient at that time. But we still want to see what's going on in your life. We still want to check up and make sure nothing has come back. So for the lower risk patients, switching to a more telemedicine and a longer interval makes a lot of sense right now. But we still want you to be a part of your care team.
Yeah. Yeah, I think it's very interesting. There's a lot of, I would say, mixed advice on that particular question out there. I think a lot of people are asking the question, am I at risk? I had cancer 3 years ago, and I've been fine ever since. And the answers I've seen are all over the place. And part of that is probably because the data isn't great. And part of it is probably because cancer is such, it's not a homogeneous disease. Every cancer is different. And so the answers are going to be different based on different people. If you had a bone marrow transplant, for example, you're basically immunocompromised for life, essentially. But I will reference a paper that just came out in February out of Stanford. And this was not even looking at COVID. This was just looking at tumor immunology is a really hot topic and has been for the last 5 or 6, 7 years now. And they were looking at T cells and how they rebound and come back after cancer treatment in breast cancer patients. And while they noticed that a certain type of T cell, which is an immune cell that hunts down, it can hunt down cancer cells, it can also hunt down invading bacteria and virus-infected cells. Well, some of these types of T cells came back after a year to almost normal levels. There was a certain subset that did not. And they believe, their hypothesis is that this this chronic immunosuppression of this T cells that didn't ever come back after treatment is why we see in some of these cancer populations that they don't respond as well to vaccinations. So that, you talk about some people get vaccinated, some people get immunity, some people don't. And some of these cancer patients who were post-treatment weren't getting immunity from some of these other vaccinations. And they hypothesize that this lack of these T cells coming back properly is what had it. And while there's no data to support this for COVID, it could kind of maybe suggest that, as you mentioned, we think of it as a lifelong kind of illness, cancer, that they might still be immunocompromised to some degree for viruses. And I have seen some people online who have said that, no, if you're 3 years free of treatment, you're fine. I do think that obviously you're at higher risk during treatment. I'm not saying you're at same risk, but to say zero risk to the normal population, I don't know if that's true yet, that we know that. I think it's too new.
Yeah, I agree completely with you. I think, we always like to say the magic number for the C word for is around 5 years. But even then, it's very nice to continue to monitor our patients, because there's always that rare case that 10 years down the road they were doing fine, but unfortunately it comes back. So I like to continue following up with the patients just to be safe.
Yeah. Is there anything that you've noticed within your clinic, within the patients you've seen, common questions or concerns that come up often?
Yeah, the common questions that come up is, am I going to be okay during this time? There's a lot of anxiety and a lot of fear. And I like to tell my patients all the time, we are thinking of you constantly, both of your safety with the virus as well as trying to get rid of the cancer for you. We absolutely want the best outcome for you, and we're working our hardest to make sure your care is delivered as quickly and safely as possible without compromising any quality for you. And to know that we're taking a lot of steps to make sure that we minimize the risk for you when you get here, so that way you do not get sick during this time.
Yeah, I think that's fantastic. It's cancer anytime is life-changing. It is, and within different medical healthcare systems, navigating that alone is a challenge. Every extra thing is a battle along the way, and this COVID has just added a whole nother layer. And I hope for anyone watching, if you're going on this journey, or you have a family member, a caregiver of someone who is, just know that we're with you, and we're all going through this together, and we understand the plight that this is right now in your lives.
That's well said.
Really appreciate you taking the time to talk with us today. So thank you again for joining us, Dr. Chowdhary.
Thank you for having me. It was a pleasure.
If you guys want to learn more about Dr. Mudit Chowdhary's work, you can follow him on his Twitter page, at Dr. Chowdhary MD. Links will be in the show notes to his pages. I recommend following him on Twitter. I follow him on Twitter. Everybody in healthcare has really stepped up for this COVID crisis, including every one of the cancer teams, and he's been documenting that really, really well. So go show your support for your healthcare workers there on his page. If you have any other questions, feel free to leave them on this video in the comments below, or join our discussion on our Facebook page. You can find that by going to fb.tumortalk.com. Take you right to our Facebook page, posting lots of cancer news and discussions every day. If you did like this video, please do like the video and subscribe to our new little channel. It'll help other people find our video series. We have a big cancer fundraiser coming up the end of May, so there'll be more videos coming out about that later. We have exciting things planned to raise $10,000 for the Cancer Research Institute. We got some exciting raffles, we got some t-shirts to sell. For now though, if you want to get early in the fundraising, we're giving 100% of our Patreon funds for April and May are going to be going towards this fundraiser. So you can donate now if you want to support, and also support this channel at the same time. That's at patreon.com/tumortalk. All these links will be down below, as well as some COVID links as well. You can see all that in the show notes. Please do stay safe, regardless if you are high risk or low risk. Please stay home if you are able, so we can protect vulnerable people within our communities, which are those with cancer. No matter where you are in your journey though, remember, you are not alone. We're in this together.